Matthew Holt. I'm here for another THCV Spotlight and Demo with Aasim Saeed. He is the CEO of Amenities, which is a relatively new player on the sort of digital front door and more for hospitals, part of the whole health technology spectrum. Aasim, great to have you on here. You spent a long time as a McKinsey consultant, and then you spent a while at Baylor Scott and White, one of those big Texas systems, and you came up with some ideas. So what was the big idea?
Yeah, so as you mentioned, throughout my background, medicine, public policy, McKinsey consulting world, and then actually in the belly of the beast at one of the largest health systems in the country, I was always flustered by this weird paradox we have in healthcare that if you think of patients as customers, which I know is a controversial topic, but something that we take for granted. We really can't entertain, and I don't deal with or have a lot of sympathy for anybody that's still fighting the fight of our patients' customers. They're customers, and in any other business, customers are measured in lifetime value. And if you did any sort of math in healthcare, the lifetime value of a patient is millions of dollars. And that's partly because it's US healthcare, and that's how much we pay, and the costs are exploding, et
It
cetera.
costs too much. Okay.
Yeah, it
Ignoring
costs
that.
too much. And we can debate whether or not that should be $1 million, but it is $1 million. The challenge is, one, no health system in the country even knows that number. Literally, even at Baylor, we couldn't define it. It was too controversial, and we didn't have great tools to measure it. But if you just think about that, that is a higher average lifetime value of anything I can think of besides like private yacht sales. And when you think about like, when's the last time you felt like the customer of a private yacht in healthcare? Meaning health systems should be bending over backwards to roll out the red carpet to patients. And instead, often it feels like the opposite, which is we go out of our way to piss off patients. Like, oh, there's a 3-hour wait, there's an 8-month waiting list. When you get there, it turns out that the doctor's 4 hours behind. Whatever it is, we're just really not attuned to patient experience. And as you mentioned, because I was at Baylor Scott and White and I had a wide purview of working on all sorts of innovation, cost reduction, value-based care initiatives, consumer. Look, I'm a bit disillusioned. I don't think we're going to save money because no one's rewarded for saving money. I don't think that value-based care is sort of a new way of networking. That's a controversial statement. But I do think that the one thing we can fix, if we just change the dynamics of this industry, is the patient experience by making health systems compete on it. And so amenities was launched really with that core thesis, which is to say, what if health systems competed on experience? One, we know the patient experience would get better; it can't get worse. And then two, but we think early movers would be rewarded like Amazon was in e-commerce, like first movers to establish and figure out what's going to delight patients or customers in a way that no one else has the opportunity to move massive market share. And just to give Baylor as an example, moving like 10% market share in Dallas-Fort Worth is worth $1 billion to a $10 billion health system. It's not small things. And so even though, as you mentioned, we're young, I think we have a very unique track record because of that experience at Baylor Scott and White that frankly no other startup can really hold a candle to. But we're not also trying to do something small, even though the technology has a very, we have to be pragmatic. We have to think about how to do the first install and try to get that live. There's all those mechanics that are, I think, very important. Fundamentally, because of my background and policy, like I'm trying to fix US healthcare with the one thing that we can fix, which is patient experience. Right. And so there is an end goal overall that is aside from the entrepreneurial and venture endeavor.
Well, it's good that somebody's interested in fixing some part of American healthcare, because far too many people are happy to ride along. Let's talk about, before we dive into and actually you show me what the experience is like. There's been a lot of players, and I'm thinking of the sort of, Kairos and Luma and others who are trying to help steer referrals around the systems. There's a lot of conversation about leakage, right? Which is kind of what you're talking about, moving market share and leakage. And one would get the impression by now, if you wander around the floors of HIMSS and Vive and elsewhere, you get the impression that this has all been taken care of, that there are tons of businesses already out there who solved the problem of primary care and other leakage. When we met at Vive, you told me that was not the case. So what What's the level of sort of I don't know what you call it in politics? You call it vote splitting amongst people who show up in multiple different systems. Even though we have these big systems that spend gazillions of dollars advertising at the baseball and the football and TV and whatever. What's really going on out there?
Well, first, can we acknowledge that we have the most awful terms in healthcare? We literally talk about a patient leaving the hospital as discharge, which literally means things coming out of your face, and then leakage for patients splitting amongst other healthcare systems. But
well, it's kind of interesting that if that Roto-Rooter is owned by the same company that owns not a hospital but a hospice company. They must have brought them in to fix the. They must have thought they would fix the leakage in the hospice. I don't know.
Yeah,
go on. Sorry,
yeah. So despite that awful term splitting, let's say, if we're gonna be a little bit nicer about it, look, there's a number of stats that I can point to, but I'll give you a couple of them. One, almost no one has a measure of what we call in-network utilization. None. That's the closest thing, network utilization management. And that is the numerator is the number of things that are happening for that patient in a given year at your hospital or your chain of healthcare system over their total spend. And literally today, healthcare systems only even know that number on their sliver of population that is value-based care, meaning ACO population or their health plan, which is typically like 10% on big health. Now, Kaiser, of course, being the exception and others like it. But for the most part, we don't even know. On the ones we know, very good in the industry is if you're getting 35% of in-network utilization. That's very, very good. That's like best in class. And I've seen some external studies that also mimic that number, like 40% in Massachusetts was like unbelievable. But we also didn't just leave that up to chance. We actually asked patients. So we've done now 6,000 patient surveys around the country, and we are yet to find a single patient that isn't a splitter amongst multiple health systems. So basically, everyone's cheating on everyone. Everyone just looks the other way, and we're all in open marriages, and we just say, yeah, they're our patient. I mean, of course, they stick with Dr. So-and-so, but that's fundamentally what we think can change. And that's the opportunity, is that like no one is currently loyal to a healthcare system. No one. Anyone who thinks they have a loyal patient is dramatically mistaken.
So now, basically what you're saying there is that if you could figure out how to make that experience a little bit better and a little bit distinct, you could bump that number up. Right?
Well, I'll say it another way is, this is to your question about like, have people solved it? The answer is clearly no. No one solved that because no one's done that. Now they tightly manage like, oh, let's get that ortho referral right back in quickly before I lose it. But that's a whole different concept than saying, what if patients actually wanted to stay in network? Because I mean, again, we use this example, it's clearly hackneyed, but at the same time, I go to Amazon Prime because of the benefits, right? Like, yeah, I know I might shop occasionally for something on Google or look outside for individual brands, but because I have 2-day shipping and free returns, my first stop is Amazon. And that's what we're looking for, is to say that Baylor Scott and White or Memorial Care or Mercy or all these other health systems, can they do something for me to where they get my first bet at saying, can they do it at all? Because I know I have peace of mind there, or I have access, or they treat me differently or better because I paid a little premium, kind of thing. That's, I think, the game changer we're betting on.
All right. Well, let's see what you've done in terms of actually putting. Why don't you share your screen and show me what does this sort of front door look like? What's the initial experience of somebody using amenities?
Well, yeah, and before I jump into the actual like clicking through the experience, I'll premise it by saying there's really two parts of this. One is you can't get loyalty when everything is incredibly difficult to do. So I wish we didn't have to start here, but we have to start by making the digital experience a little bit better. It is 2024. Nobody wants a phone-in membership. I mean, so we have to fix a lot of the baseline experience. And then the second part that I'll show you in the same experience is upgrading them and offering the memberships. It can be done a bunch of different ways. You could leave everyone to the default baseline standard, which is the current patient portals, and exclusively have a membership offering. But we also think that a lot of the first tools I'm going to show you are applicable to the public more broadly. So I'm going to show you mobile. We do this on web as well, which already I can think differentiates us because, again, we know that is a necessity. At Baylor Scott and White, no matter what we did, half of the volume stayed on web. And so if you don't have a web component in your mobile-only solution, you're already missing half the population. The second thing I'll point out right away before I again start clicking is it's white label. So there's no amenities brand in this. This is about the health system, Sacred Heart, Baylor Scott and White, Mercy, Memorial Care, et cetera. And so you'll see that right off the bat. And then the third point to, again, start us off before I even click is, this is completely continuous to the EMR. In most cases, especially with the health systems that we're talking to, that's Epic. So when you cut over, no patient resets their username and password. This is logging them into MyChart. And that's, again, very unique, because I think we hear this concept that, oh, we need to add another identity management layer. Oh, we need a CRM layer. Look, healthcare systems are so broken that anybody who wants to add complexity to the infrastructure, I think, is barking up the wrong tree. We've kind of a foregone conclusion. The EMR, and especially the ones moving to a single instance of it, that's your default system of record. We need to be plugging into that. But those things are frankly lacking in a really core set of functionality that we are trying to fill in the gap. And the first and foremost is, you can't get a new patient in. And so often we ask, well, what about what can you do in the app before you log in? Well, like, that's the wrong question. For us, it's, why can't you log in immediately? Why can't you sign up instead of throwing a bunch of stuff on the outside and then not getting any credit, no visibility into who's that patient, why they're coming to you, et cetera. And so we've made sign up really simple and easy. And today, this looks like the Experian credit check. Literally like 30% failure rates, 50% plus drop-off rates. Nobody even knows it exists. And most health systems aren't advertising their app. One, because everyone has the same app. What's the point of advertising something if it's completely undifferentiated? And then two, it's because it's not applicable to new customers, new patients. Whereas I think that's the first thing we fix. So if you go into the sign up button, we don't do this lightly and say, oh, we'll just take a username and email, and then you'll have to deal with it on the back end with a bunch of duplicate accounts. No, we ID verify them. We use telecom data here. And after we verified they're in possession of the phone by sending them a link, we ask them one very simple question that 99% of the waking public knows, which is, what is your date of birth? And with that, we can autofill all this information. And that really allows us to do very unique, under 30 seconds, no data entry. And from there, we have in the background sent that to the EMR, ensured that there's not currently an account, and then said, let's register a new one. And again, adding now a username and password, in under 30 seconds, I've created a full electronic medical record account as well as the patient portal account. And that is something that, again, I can't tell you why, but like 9 out of 10 health systems don't even know they're missing right now. But I think it was the first thing we were like, let's get them into the system right away, and let's take out as much friction as possible.
So how but before we even got to that part, how would they get to this part? Is this they come to the website, they come to advertising, how now you can
Yes,
do this? How's health system advertising it?
Yeah, that's a great question. So to be very clear, we are in the business of loyalty to brands that are well known. And that's why we're not doing direct to consumer medicine where we go launch amenities to the public. So they came to this, as you just said, a couple of different ways. One is by going to the website, which has typically for these large health systems, hundreds of thousands of visitors a month. And what happened in the case of Baylor Scott & White is, and this is kind of incredible if you think about it, this many people went to the Apple App Store and typed in Baylor Scott & White Health.
Wow,
and found
people are doing that? That's amazing.
500,000 people did that from my time when we launched it in 2020 till I left Baylor Scott & White in 2021.
Wow.
It's unbelievable, because that's how, by the way, that's how powerful these brands are. And we're often asked, well, what about paid search and other things? We don't have to do any of that. You have so much brand equity right now, especially in growing markets like Dallas-Fort Worth and other these major cities, that if you just were the only show in town where it was very clear that you could be the only place that you could download the app, register, add your spouse, and book an appointment in 2 minutes, it's going to work. And that's this part that I'm showing you here. So first step was just register. And then inside of the app, we also, again, have upgraded the experience quite a bit. We show them, because we're set up for new patients, not just coming in to get my lab results, we show them, hey, you can add and manage your entire family. The lowest hanging fruit for every health system is for every current patient to add their spouse. And again, we don't make this easy. We treat you like a criminal if you're trying to get your family's medical. And so we made that easy. We say, hey, here's not only provider search, but here's all your same-day care options in one place. So you don't have to go hunt and peck for like, oh, they have a Teladoc partnership over here. Oh, they offer some e-visits, et cetera. And then finally, as we said, this is fully continuous to and shortcuts to the mainstay of patient portals, results, messaging, billing, but also it could do that with multiple patient portals. And unlike doing it with, exclusively MyChart, especially if you have other EMRs in your network or other providers on different EMRs and you want to integrate those, that's something that you obviously need to be using a third party. And so what that experience looks like, just to kind of walk you through, is one, Again, you can manage anyone, you can add and invite. Because we can register new patients, you can send a link to a loved one and they can click that. And as soon as they spend that 30 seconds to register, your accounts are automatically linked. And now you're proactively managing your family. You can see all of your same-day care options. That's typically e-visits, video visits, urgent care, retail, walk-in clinics, etc. But we show you them. And in fact, we can pull forward the times and show you what's the earliest availability for video versus the next available in an urgent care. Or you can do the typical, which is you find a doctor. And again, this isn't rocket science, but these are just incremental things that we think are missing. Is this needs to be sorted by next available, and less than 1 in 5 health systems even have that capability today. Because why are we making patients hunt and peck? In Amazon, you can quickly sort order by price, low to high or average rating. And yet we just literally, I can't tell you, there's half of health systems have a provider search that is literally just A to Z, and poor Dr. Ziad is just getting screwed on that website.
Yeah.
Because he's he's on page 7 and no one ever goes past page 1. And so that's just silly and ridiculous, I think, in 2024.
Oh, I can go worse. I had a weird thing with my eye and needed to find an ophthalmologist very quickly, and we'll discuss membership later. But my friends at One Medical couldn't direct me to anybody, which I thought was bizarre. They said go see your ophthalmologist. I didn't have one, and I ended up, I think I Googled Marin ophthalmologist. There is a Marin Health, and I got a list and was hunting and pecking. I was
Well,
calling down the list trying to find somebody who was available. It just was.
that's exactly we are leaving. Again, think about that walking. This it sounds terrible and a little bit vulgar, but like think about patients as walking $1 million money bags, like Scrooge McDuck would see them.
Absolutely, yeah.
And we're like, you know what? No, let's make that person guess it if we're available and call us one by one alongside all of our competitors. That's what I mean. Like we should be rolling out the red carpet, making this easier. And we have all these debates. Well, doctors don't want to have open schedules. Too bad. This is a business. You need to have open schedules. Now, there's a more nuanced conversation to be had about specialist visits and are you the right patient for the right type of doctor? But there's ways to handle that as well. There is no excuse for primary care. Everyone should have open schedules. You are by definition an all taker. So now, on the provider search, this comes with provider profiles and then scheduling appointments. And the goal for us, unlike I think some of the companies you mentioned earlier, is not to take over every type of scheduling. It's because one, there's like 15 different types of scheduling now. There's, open schedules, direct schedules, event scheduling, referral requests. There's request and appointment forms, etc. We're trying to do the mainstay ones. So things like open schedule for primary care, urgent care, virtual urgent care, because those are the ones that new customer to make them a patient are critically important. And the other thing that we encourage health systems to think about, which is often new ways of thinking for them, is that each question you put in front of this is going to drop off 20% of patients. That means less than 1 in 5 people who start scheduling finish it. And we have health systems fighting to put in 7 more questions. Be like, have you ever had COVID? Have you ever coughed? Have you ever stood on a bus next to someone with COVID? And we're like, the day has passed, but it's also just, it's not critical to ask these things, and you're destroying your conversion rate if you think like an e-commerce platform instead. But often they don't have those numbers because, again, patient portals today are not built to be an e-commerce platform. And that's really how we view ourselves, is layering on top of this, really focusing on acquiring a new customer, helping them find an appointment, book that first one, and then, as we'll talk about in a second, upgrade to loyalty. And we'll talk about your One Medical experience here in just a second again. So that's the experience. You get in very quickly, book, now a beautiful app like this that goes to a brick wall is not going to work. So we don't create the availability. But one thing that we hear ubiquitously from health systems is, well, we don't have access. If you have more than 100 doctors 100 primary care doctors in your network, you have 10 appointments available today and tomorrow. And I know that because Baylor said the same thing. And you can go to bswhealth.com any day of the week, any day, any time of day, and you will find 10 appointments today and tomorrow because they are sort ordered by next available. You have more availability than you think you do. Then secondarily, you've bought all these tools that no one knows how to find, put all your same-day care options in one place. And then finally, if you still don't have primary care access, then let's talk about upgraded memberships, because that means access is at a premium and it's trying to upgrade patients into members type of thing. And so the last thing I'll point out is we're the only third party. Again, many other applications that we compete with, we're the only third party that can actually click into and then go straight into my chart and not have health systems lose a step of what they've done there. And that's important because, again, we're not trying to replace the system of record. We're trying to augment it with features it doesn't have. Now, often we get into this like rabbit hole of, well, we want every feature of MyChart back into this. Look, we're never going to out MyChart. And at the end of the day, the critical features by their own utilization numbers are results, messages, billing, maybe medications, allergies. Beyond that, there's 100+ different other features that frankly don't get utilized if you look at them as a total percentage. And so that's a debate to be had, but it's something that we say that's not the goal of what we're doing. If you're just trying to make MyChart prettier, that's not the goal, and frankly, that won't bring you the return that you're looking for.
So, and then the last part is you can presumably go from here if you want to start the visit. It integrates with whatever video system or whatever else they're using.
Yes, in fact, it'll use Epic Video, it'll use Zoom, etc. And in this case, we also, because we don't want to be a closed off system, we've already had integrations fully with TytoCare, Hypnosis, BrightMD. And so there's a number of other solutions, and then we can add more. And so one of the things we do is we ask health systems, what do you already have in place? Let's bring those together. Our goal is not one app to rule them all. I think that's just impossible in today's modern age, but for patients, less apps is better. Like one place to start your journey for everything that Stanford is offering you, or UCSF by you and others. So,
well, if you can get
so all of that, what's that?
I was going to say, if you can get UCSF off what I had recently with them, which was call this number. It'll ask you what kind of doctor you're looking for. I had a back injury. It asked me. I was given a referral to a. This is classic American healthcare. It's what we need to break, right? So I'm in the ER. I have a back pain, big problem. They discharge me. They give me in the note, so I can go into MyChart, and they give me a piece of paper telling me go talk to this doctor who they refer me to. Didn't bother with anything, trivial like a phone number. So I Google the doctor, get a phone number. The phone number is the UCSF Spine Center, which is fine. The first question is, do you want a neurosurgeon or an orthopedic surgeon?
Oh, which one do you want, Matthew? Come on now. Which one are you looking for?
And eventually you end up you get through the phone tree, and the answer is leave a message, we'll call you back in 3 days. And fair enough, somebody did call me back in 3 days, but it's like,
But now you're in phone tag hell.
No,
right?
absolutely. Now I'm trying to call them back again, and God knows.
Yeah, exactly. And heaven forbid, you have to go through the phone decision tree just to let them know that you got the message to call them. I did this with a urologist recently, by the way. It's exactly what you're saying. But that's what I'm saying. Do you think like Amazon or Target would ever do that? They know that friction means that there is a 50% chance that you never get that referral. And that is, I'm amazed you got the referral that said call.
Actually, well, I leaked, right? I ended up doing it outside of you.
You didn't end up doing it.
So,
and by the way,
I was in your 70%. So there you go.
You were, but not even that. And think about how crazy this is. You are not looking, you don't have a cold and you're not going for primary care, which is like a $150 visit. You had back pain for a neuro or an orthopedic spine consultation. You are literally upwards of $50,000 to $85,000 in potential revenue that just didn't show up for the visit because they made it so damn hard. Like that's the insanity. But that's what I think we're very clear that like health systems don't compete on experience because they have this weird mixed emotion about being for profit but not profit, but a public utility but not, because we still got to make money. And at the end of the day, I think the first movers who get past all this and realize that we need to delight patients will win the market in all these major cities.
So let's go to the next part, because you mentioned a couple of times just the membership issue. So show me what you mean, because to me, this alone, something like this, which can get me to the right place much more quickly, and I can get there from, because I'm pretty sure I have like 3 MyCharts. I think I have Sutter's and UCSF's, and then I split it between my kids and what. Yeah. So something that would be, and I have a couple of versions downloaded on my phone. So, and I'm not a heavy user, and then I also have the one medical thing that we mentioned. So there's a bunch of stuff going on. One central place just for one system would be great, but I think that's probably enough to actually shift market shares. Volume. But I mean, like you said, they could have got my back pain, which luckily didn't end up being $85,000, but could have been, right?
Yeah, I hope
and maybe later if I get older, which is where you're going.
Never seen. Yeah.
Which is eventually, right? Maybe later. So but show me the next part, because you think there's another leap, which is that they can
Yeah,
actually start doing kind of the Amazon Prime membership, which is kind of ironic
absolutely.
because now I'm an Amazon Prime member. My one
You
medical,
are because of
my
one
one
medical.
medical membership has actually got cheap.
Yeah, it is. It is.
But
And
anyway,
so most people don't realize this, but and we've had this conversation before. So One Medical is being subsidized by these health systems. I know that
yeah,
because they came to Dallas and they came
sure.
to Baylor and said, let's do that. And Baylor's now their new. But what people don't realize is those health systems are subsidizing everything. They have to pay, it's at minimum a 10 to $20 million investment a year for 10 years to partner with One Medical. So now health systems are literally paying Amazon to disrupt them.
Yeah.
So that's a fun tidbit. But I think the bigger problem that I had when we were making that decision at Baylor was, why are we introducing One Medical brand to Baylor where it has zero brand equity? Baylor Scott and White has 10 out of 10 people on the street in Dallas would know what Baylor Scott and White was. 0 or 1 out of 10 would know One Medical because it's not San Francisco or New York, right? And yet we were paying One Medical to come do a better experience. But we all know that better experience is I can get an appointment tomorrow. And as I already said, you can get an appointment tomorrow at Baylor Scott and White. It's just not as well known. And so I think the idea here is health systems have brand. They should be doing memberships for sure. I love that concept. Obviously, I've been effusive about it. But the idea is they shouldn't have to go to One Medical to do it. And so to your point, we build and design amenities. And here's where the name comes in. We are literally the amenities for these health systems. So we design and build these memberships. But I think one thing that we tell them right away is, one, it has to be better than One Medical. You can't just be like, okay, I'm going to open up a crappier One Medical, which we've seen around the country with these health systems trying concierge care. And two is, let's actually do something new and creative. And what we found in all of our research is, yes, access is a problem. We've kind of made that point 100 times over already today. But it's actually not the number one problem for most Americans. The number one problem is the cost, as we started at the beginning to say. And that shows up in research we've done, but it also shows up when we ask them what features are most attractive. And the number one feature that's most attractive in every survey that we put it in as an option is no surprise billing guarantee. And that is us offering to productize the No Surprises Act. And so when we say memberships, we think there's this massive missed opportunity of saying, yes, you could do upgraded access like this here. You could even do concierge care, like 1 hour visits. But there's a very low cost kind of Apple Care like protection plan that says, okay, you guarantee you're not going to give me a surprise bill, or you're going to review it for changes. You're going to review it for errors, which happen way more than any of us would like to admit. You offer a satisfaction guarantee. You give me cash pay alternative pricing. All these things are really important because these are the types of things that, again, we don't guess. We research locally, we design, we build, we find the partners, we integrate, and we launch as a fully branded membership, because then who gets the benefit is Sacred Heart or Baylor Scott and White or Mercy, Memorial Care, et cetera, because we think that's the value is let's get them sticky to your brand. And then the last thing I'll say on the One Medical comparable is just think about this. I think the only thing that One Medical has proven is that if you have a concierge primary care doctor, you are not loyal to the specialists in that network. As you just said, they gave you an ophthalmology, they gave you, emergency department. I think that was at UCSF, but like, there's no closure with having rich concierge primary care access to actually staying in network for the specialist. But if you have financial protections that are no surprise billing guarantee for big dollar things like surgeries and procedures, where are you more likely to use those? You're going to want those to be at the institution where that's giving you that protection. And so we think not only will they be a much larger, more scalable, low cost membership like Amazon Prime, but they're also potentially far stickier than primary care, concierge primary care memberships.
So let me ask you about the rates you had there with the different pricing, right? Because so I go back to it. So One Medical is, just $18 a month or $20 a month. It's kind of that middle layer. You do get some of the stuff you're advertising there for the more expensive one. You get the same day appointments and the 1 hour visits and what have you. So what do you think so let me ask you, what's your experience so far in rolling this out? I mean, and what have people gravitated towards, and what's the uptake? This is like my wife used to work in video games, right? And those free video games you download, 98% of people never pay any money, and they make a gazillion dollars on the 2%, and the top 0.2% is half the money, right? People are addicts who are paying for enhanced guns or whatever the hell they're paying for in their video game. Is this what's your model here, and what are you seeing so far in terms of uptake?
Yeah, let's go to this. So first of all, that first category of doing the application and getting rid of all the friction and just
That's
dramatically
free, right?
improving the experience. That's where we're live today with customers. So that's
Okay.
what we built. That's where we have
Okay.
the track record. That alone at Baylor Scott and White led to 500,000 net new patients and hundreds of millions of dollars of new contribution margin from those patients alone. The memberships are early days, so we
Okay,
are
so you're not
in development. Yeah,
this is theoretical rather than lots of
yeah.
data. So far. Okay.
Well, one step further than theoretical, we're in now partnerships with health systems to develop these.
Okay.
And but one thing that I'll tell you is, so again, with that McKinsey background, I'm very well versed in the unit economics here,
Right.
and you're absolutely right that One Medical is kind of a steal at like now I think it's as little as $9 a month, right? But the reality is that's only $9 a month because health systems are paying $50 to $75 per member per month for you. Like One Medical is not profitable, has never been profitable, never will be profitable. It is a loss leader now for Amazon, and it continues to be a loss leader only if massively subsidized by health systems. So if health systems want One Medical to go away, they can just stop signing up for those memberships. But I don't even think that's a good thing. I think One Medical is fine. We should have it, and the market needs more competition. What I'm saying is these memberships, we only design and build ones that are profitable. But the goal is there's two things. They're profitable, meaning we do revenue share with the health system.
Yeah.
So at the $9 or $19 a month, first of all, there's a willingness to pay for every one of these anywhere from $20 to $30 per membership per month. So we've done that repeatedly, and that number's come up. But the second thing I'll tell you is we only design and build things that are scalable and replicable, meaning we have profit margin built in, so much so that we revenue share with the health system. But the last thing I tell health system is that shouldn't be your goal. Now, we all want to build break-even businesses. The goal is the loyalty downstream. It's the in-network utilization shift that comes with the 10% who stayed in network. That's the massive billion-dollar opportunity. This is just how we get there. And really, as we all know, whether it's our Amazon membership or Netflix or whatever, Apple One, whatever you might have, membership today need to feel like a steal. Like you're getting one over on the company. Like I order 5 things from Amazon in a month, and the shipping alone, I'm like, I took them for a ride because it would have been $10 each. That's how good these have to be, no brainer. So we do need to, like, where we're starting is not where it needs to grow to. You need to figure out the 2-day shipping and the free returns of this industry, but you have to keep layering on more and more. And then frankly, you just need to move the market share that says, hey, you are so successful that this is a no-brainer to keep packing this in and everybody wins.
So my guess on that was at the first level is I'm surprised about the no surprises billing guarantee being such a big deal, but obviously it's come up and there are and yes, billing is a nightmare and there are surprises and we've all had those examples. I think the same day consult to me is a and the automatic video is, I think that's a big plus. If you go to the One Medical app, you can get an MP on the line and frankly, this is a place where I think health plans have really missed out because they could have some of them have got like Teladoc or Amwell, but they don't feature it, whereas this is like that's to me an automatic loyalty thing. But well, how do you comment on that? Because the next layer I want to go to is I think that where it all falls apart is navigation for people who are actually sick. So comment on the first ones I just said about how you think those are.
The first one I would say is, having been the person responsible for a lot of virtual health at Baylor, I can tell you that like this is just unfortunately a massive political conversation internally.
Okay.
It always ends with some silly conversation about who's the C, who's the customer in healthcare. Is it the doctor? Is it thing? And by the way, these are fully employed doctors that they're like, who's the C? Like they're not your customer. The patient is your customer.
Right.
And we have it's one of our tenets of values. The patient is the customer. We don't apologize. We don't have a lot of sympathy, and we don't have a lot of time dedicated to that conversation. But the second thing is they're not promoting it a ton because then they're like, well, the doctors will be upset that we're stealing from them because the RVUs are so it's all this game. But I think at the end of the day, one thing that we know for sure is the world of you having a single doctor for 80% of your life that your kids are going to get to know is over.
Yeah.
Doctors move, we move far too much. And so literally the urgent care specialty, which is not a real specialty, came up because people couldn't find a doctor anymore. And it is now 10x the highest volume keyword search for any medical specialty. And that just means that people are optimizing around convenience, and we're just tooth and nail fighting to maintain the status quo. And so our proposal to health systems is, look, unlike One Medical, unlike Teladoc, whatever, we're not asking you to throw our name in the mix here. We're saying, in fact, amenities, even at the memberships, is an invisible name. Nobody's going to know that's amenities. Your brand is paramount. You just have to get past this whole like, well, this division doesn't want this division to have too much. Well, too bad. If you want your brand to be successful, you need to operate as a whole company. And you need to make sure that the customer has seamless interaction with all facets. Now, your next question about navigation is very fair. And I'm not going to bullshit you about how the app solves navigation, because that is really hard. Now, one thing I can tell you is we've taken out, I don't know, 3 of the top 7 or 10 or 20 problems that are like, I can't even get into the app. I can't even find my earlier appointments. I can't even see who is in my network, and I can't even see when they're available. So I have to call, and it turns out I put it off for the next 5 weeks. We don't solve the just yet, like, hey, did they accept all my insurance? Now, the app can do that. It can look up insurance, but it's not us. It's Epic doing that on the background. And then the other thing I'll say is health systems have invested in resources that go completely underutilized. So just to be clear, one of the things we hear all the time is, oh, we already have payment plans. And that's one of the things, financial assistance and payment plans is on the top of our list too. Which patient knows that health systems are going to have a payment plan for them? They're like, yeah, we put it in the bill. I'm like, oh, you mean that one hyperlink on the 18-page PDF that I get? Yeah, you've put it in the bill. And then we kind of, wipe our hands and say, we're done. They all know that we have payment plans now. Like, no, they don't. And so there are navigation resources and other things that aren't being properly advertised and utilized because they get buried in the bureaucracy of healthcare. So we don't have a navigation service per se, but we would build that. And we have tested things like, for example, insurance concierge. But the reality is, unfortunately, insurance concierge, the best one that we found to partner with, is specific to a known insurance. And so in other words, we can do it with the health system inside the membership for Medicare, self-pay, and the health system's health plan, but we can't do it for every long tail of one, because to really navigate you, especially according to insurance, we have to deeply understand your explanation of benefits and other things. So these are all things that we've considered, but we're also very pragmatic about which problems can we solve in a scalable SaaS way that is profitable to start with. And then we can add more things more along the way, because I think to your point, we want to get to the rest of the 15 things that are awful about the experience, but we're also pragmatic about starting as a technology company.
No, that's fair enough. All right, real quick, Aasim, just give me the background. So when did you actually start the company? How much did you raise? Where are you in the rollout? How big are you? Just give me a sort of flavor of.
Sure. Yeah, we are just a little over 2 years old, end of 21 when we first started. We have a couple of marquee clients that are live with the application. That's really exciting. We're in partnership with a few early stage health systems that are very
Can you name the names of the clients?
Yeah, Memorial Care. So Memorial Care, sorry, I skipped over your investment question. Memorial Care out of the Southern California led our Series A, so strategic. We've raised just under $10 million, so still a very kind of efficient team. But we are live with Memorial Care, and at the same time, Mercy is another big client, and working on several more. And so some of the partnership ones, though, are early stage and NDA involved, and so it's all hush hush until we get to go live and announce it. But very excited about that, because we're trying to prove a lot of things. But I always say, like, technically we're 2 years old, but we have 4-year track record with MyBSW Health as the most successful app in the country. So we're a bit of a hybrid in that regard.
All right, you haven't convinced them to rip that out and put yours in instead yet, though. A bit tricky if you build that one.
We're always working on things. But the reality is that's a very expensive proposition. There's not a health system in the country that has built a custom application for less than $2 to $5 million a year that we've seen, and we are a fraction of that time and cost. The reality is no health system should be building this. This is just too much investment long term. So.
Well, interesting. All right. Well, we'll leave it there. I've been speaking with Aasim Saeed. He is the CEO of Amenities Health, which is not that new an entrant, as he said, but certainly we're shaking things up in that whole digital front door to health systems market. Aasim, thanks for your time.
Thank you so much.